Second stage, you know, a lot of times, you know, we'll get a CT scan, and that's why I call it a post-span CT. And we do use this for surgical planning, when to do, you know, I do it when the soft tissues are ready. So I'm pretty aggressive with these because if you wait too long, you can have problems as well. But usually it's about a week, 1 to 2 weeks, I would say, is the most common type. And then, you know, obviously, if we need a flap, we have to, combine that with a plastic surgery procedure. So these procedures are planned out. I know them in advance. It's not like I'm adding on a second stage Pilon just in the afternoon without, you know, kind of knowing well in advance of that. So here, Nick, you want to go over this slide a little bit?
Yeah, I mean, the point is really looking at the articular injury once you've kind of got that ideally after you got the tibia out to length. And so I really like looking at that axial view, the one in the top left corner, because it really helps me understand the fracture pattern, and then it helps me understand how I can access it, because I really want to be able to look in through the fracture fragments. You know, so for this case here that Jan has, you know, it's very common to use, and I know that's coming up in a little bit, but like an anterolateral approach, for example. And if you came in from the anterolateral approach, Jan's going to show you kind of where you're going to be looking. You're not going to get a great view into that, in through that fracture, and be able to see those articular pieces. So that might be a case where you actually want to come do more something medial, or dare I say, even something more anterior, which it seems to be even more popular now with arthroplasty and anterior ankle fusion plates when they think about, you know, secondary reconstruction options. But that's the view I get. I posted this on LinkedIn that they sometimes will refer to this as a Mercedes sign, because you can see the 3 pieces to it. It's not you know, a perfect Mercedes sign, but you can kind of see it, and you see that pattern over and over.
No, exactly. And I think that's the big thing here is you know, when I'm thinking about a Pilon, which approach, or not only which approach to do, but it helps me think about what plates I'm going to use too. And that's why, like, you know, systems that have multiple plating options are very helpful. Also mini frag. I always ask the surgeons to have an open and a mini frag for this, because even though you might need a larger anterior lateral plate, which is probably your workhorse plate for most systems, you're going to use mini frag and so forth. So 2.0, 2.4, 2.7 screws and small plates are very helpful for most of these fractures. So always bring those things along, because for this. So it's not just a plate, not just a simple, not simple one plate. And then here's an articular, a 3D recon. And I think these can be very helpful, just, you know, looking more even where you're going to go for, like, how you're going to fix this, but also your approach. So, you know, I get these routinely on almost all periarticular fractures now.
Yeah, and now it's nice because at least our system, I don't even have to order it. I basically can click a button and it'll flip it into a 3D recon, which is really cool. Unless the splint's there. Splint doesn't work that great if that's there.
So I think this is just very helpful for pre-op planning, and then even for, like, I know the reps that we have, they're great, you know, trauma reps, and they actually will pull this up and look at it, and they'll be like, oh, you're going to go medial on this, you're going to go direct anterior. Like, they know, like, they've seen enough. So they're like getting planned, they're planning with a lot of the you know, implants already, and they know kind of what, you know, what to expect. But they do a lot of this with us. So and then Corey said, do you prefer the reps to review these images pre-op with you? Yeah, it depends on the depends on the rep. I don't mind at all. I think it can be helpful, like, hey, we're going to do this and then that, because, you know, sometimes like the rep will be like, oh, hey, yeah, we got these the other plating system. It's you know, whether for the mini frag, or they call it like the fracture plates. They have all these different, like, or foot plates. He goes, oh, do you want to maybe try a foot plate on that? It looks like it would work there. So they can kind of, you know, my reps will give me like helpful hints and tidbits and advice on those things. So I think it's going to be very helpful. And then when they see that fracture pattern another time, even if I don't review it, Corey, that they have those things ready because they're like, oh, he always, when there's a, Chaput, he always puts a mini frag here. So Chaput is this fragment right here. He always plates that with a mini frag. So they know to have the mini frag ready to go. And I love that. It makes the day go a lot smoother.
Yep. Can you talk about the three pieces there, the Chaput and the Volkmans?
Yeah. So
do you want to go back maybe?
Yeah, I don't know if, hold on here.
Here we go. Yeah.
So the Chaput, if we refer to it, is the anterior lateral piece. And that's important because the syndesmosis attaches to it. And then the Volkmann is going to be the posterior lateral fragment. And that the posterior part of the syndesmosis attaches to this. And then you have the medial fragment here as well. So those are going to be the main three fragments, that for a Pilon. Anything else, Nick?
No, I think just recognizing that there's a fairly predictive or fairly consistent pattern that happens with these, I think will help you a lot. If you can just look at that axial view and just realize, hey, okay, I see the three pieces. I think he's going to come from this side. Then you can at least just start to think about what the plating system is going to look like. And that, I think, just gives you a leg up on what to have ready and available to go.
Exactly. And that gives us the fixation construct. So anatomic articular reconstitution. So that's going to be with some independent, maybe lag screws. So you're going to want to think about having small caliber screws, I think, at the joint. So when you have like 2.7 screws or 2.4 screws, because you don't want to take up a lot of real estate with before you put your main fixation down. So I think that, like, once again, I'm a big fan of mini frag if people haven't caught on to that during this talk so far. So, have those smaller caliber screws ready. And then we talked about the varus deformity and the valgus deformity, where you want to put your plates. Like, think about what would the fifth grader do? They're going to, push the bone back into the right place. So think about plates that could help that. So, when you're thinking about maybe making sure everything is there for that particular fracture pattern. And, once again, we went over this already, but, the fifth grader would push this way. So you're thinking about some type of medial support. Here, you'd probably use an anterolateral plate. I'm a big fan of using some of these. I just used it a couple of weeks ago, an anterior base plate for this type of injury, Nick. It was, it was already pre-contoured. It was the first time I used a pre-contoured anterior plate. It worked pretty well because, like you said, these anterior impaction here, where that you could see how the talus wants to go out the tibia.
Yep.
These are very difficult to treat. I don't know, what's your preferred fixation pattern for that?
Yeah, I mean, it's the same. I haven't used that specific plate, but usually it ends up being some form of a T plate, or something a little bit like a buttress plate. And then I've used more of those rim plates if there's a lot of impaction as well. I was thinking about those, because that you look at that case there and you think, oh, that doesn't look so bad. It looks like kind of one simple piece, but as the great lyricist Taylor Swift said, that's like a nightmare dressed as a daydream kind of thing. So those are problematic.
Wow. So just quickly about the approaches. So Nick keeps on pointing out the axial scan, and this is where I 100% agree with him. This is where we're looking at how we're going to approach things. So here it exits out. This is medial, and so I'm thinking I got to do something here usually. Mm-hmm. I could go here and flip this up, but if I do this, I got to take off the syndesmosis. So usually I'm going to try to, I got to think about an approach that gets me through that fragment. The anteromedial will just, and then here's like it's probably the workhorse is going to be the anterolateral fragment. You can see here, that's where the money is, right? We're simple people. Orthopedic surgeons, we're simple. There's a space here, we're going to use it. And that's where I would take my approach to access any of the articular impaction. Nick, any other suggestions here?
No, I just think, just thinking that I think you're going to see more people using a direct anterior approach.
Yes.
I think that's going to be more popularized. And again, thinking of secondary surgeries. And so I actually made a small video, maybe 5 minutes, 8 minutes or something, that I'll put on the YouTube channel, going over an anterior approach and kind of using the Pilon axial view to talk about it. But then you can kind of look at it to kind of understand the benefits of that and some of the downsides as well.
Yeah. And I've gone to, I would say 5 years ago, I would almost never do a direct anterior, where now I'm doing a direct anterior, I would say well over 50% of the time.
Yep. Agreed.
So I've really changed. It's my workhorse approach now for a Pilon.
Yep.
So that's anterior lateral. And then you have the posterior lateral, which is the same posterior lateral when we're doing like an ankle fracture. It's nothing new to any of us. I think we've seen it. And that's, to gain access if we need to buttress usually that Volkmann piece here. That's another, I guess workhorse that's for both ankles and Pilons. And combined surgical approaches, usually I'm using more than one approach. I think I would say seems like almost 100% of the time. I never want to say always, but I'm usually combining two surgical approaches. Nick, how about you? Are you staging it? Or are you just doing everything through one approach? How are you treating some of these injuries?
If the ones I stage are usually ones where I want to do ones, do something prone to get to something to the back, and then flip them and come back another day and do the front. That's probably what I'm doing the most if I'm going to stage it. If I think I can do it all from the front, more likely than not, I'm going to do the whole thing.
Yeah, me too. I think that's basically what I'm doing too, unless I have to flip them, like you said.
Yeah, that's painful.
So considerations, a lot of times we're going to have some pre-contoured plates available, especially anterolateral or medial. And then I do want to have locked fixation available, whether I use my mini frag or the anterolateral plates, because, these are short segment fixation. You don't have the greatest bone, a lot of comminution. So, combination of locked and non-locked screws here, I think are very helpful in any type of the fixation here. You want to have that ability to choose. And so, some of the fixation patterns, you can see someone asked about the fibular nail. You can also use a fibular screw, especially for some simple fracture patterns. Contouring some of your own plates, you don't have to necessarily use some of the pre-contoured plates are just do not fit. So I think having other plates available that are malleable can be very helpful to the surgeon if they need to have some fracture specific plating options. And then here, workhorse anterolateral plate. And it's important to note that even if a surgeon does a direct anterior approach, they can still put an anterolateral plate on. They do not have to do an anterolateral plate through an anterolateral incision.
Yep.
And then you can see a lot of times you'll use distal locking screws here, just because these are going to be, short segment fixation. You don't have great bone there.
Hey, Jan, can you give some pointers on where you want to see that anterolateral plate sit? Like how distal, with it, when it's contoured like that, I sometimes struggle a little bit. Is that too far distal? Where are my screws going to run out? Am I going to run, am I going to run them into the joint?
Yeah. So for me, almost always I put independent lag screws first to get the joint reduced. And then I put the plate where it will fit the best.
Okay.
So I'm a little bit, if you're trying to lag through the plate distally, that can lead to a problem, because these plates are fairly strong and robust because they're made to withstand a lot of forces. So I think that can cause a problem. So I try to get the reduction perfect, and then the plate is just, basically neutralizing or supplementing my fixation. How about you?
Yeah, I think that's the ideal thing. I've had a few in which I probably have done that, where I've lagged through the plate, or my fixation was mostly through the plate. And I think you're right. I think that can create some issues.
Yeah, and I think here that another fibular screw, I think the fibular nail guys are gonna hate me, but whatever.